Good morning, Santosh.
Good morning, sir. Good morning, sir. How are you, sir?
Good. I'm fine. Good morning. Good morning.
So, heat over here is coming down. All schools vacation was extended till this week.
I see.
Because of
Well, we are having a heat wave. It's really hot today. I think it's 40 plus. Heat index is 44.
Oh, it's
And
slowly
we had
coming
rain
down.
last week.
Okay.
It's going to only increase from what they said. Next 2 months will be hot box here.
The monsoon is slightly delayed this year, but
yeah, that's what I read in the news.
But the cyclone which developed is going towards Pakistan, Gujarat and Pakistan. So not much rains here. So probably from next week, Kerala will start having rain.
Yeah, that's what I read, that the third week in June is when the monsoon is going to come to the coast.
Yes, sir.
Anyway, have a good meeting. I'll be listening and talk to you later.
Yes, sir. Thank you, sir. Mas, shall we start?
Yes, sir. So is my screen visible and I'm audible, sir?
Yeah, please go on.
Good morning. I'll be today speaking about management of MCL injuries of knee. In this article by Chen and Co. They divided the management of MCL, as we all know, that we will be addressing it in chronic scenarios, and most of them are conservatively managed. And what are the operative indications of the same? Repair and repair with augmentation, and what are the options available in chronic MCL insufficiencies, that is reconstruction. In another article by Halinen, while randomizing 50 patients with the MCL management, operatively and non-operative management of MCL injury with early ACL reconstruction. This is a prospective randomized study. Out of 50 patients, they came to a conclusion that either patients did not had any difference in functional outcomes, those managed operatively or non-operatively. So they concluded that ACL reconstruction without MCL repair in early phases had similar outcomes. So they discouraged repairing MCL. As we all know that classification of MCL by American Medical Association into 3 grades and subdivision of 3rd grade into a further 3 grades. Though in this article by Hadia and Co, they advocated that this classification does not give us an idea about management option with respect to classification. So they tried to classify the MCL injuries into 5 categories, as shown in the tabular column and subsequently explained. Type 1, they called it as pre-avulsion phase, wherein there is a contusion of the condyle, femoral condyle at its attachment. So they advocated this to be managed conservatively. Type 2 was a proximal avulsion from the femoral side. They suggested it to be managed. Type 3 was the intrasubstance tear, and this is the subclassification which usually comes under KD3M classification, and this is where the debate of conservatively management and operative management comes in, and the authors left that inconclusive suggestion as well. Type 4 was a version of the tibial attachment of the MCL. It may be bony or not, or the intrasubstance avulsion. So the author suggested it to be operatively managed. And type 5, they called it as sleeve avulsion of the tibial attachment of the MCL, where there is buttonholing of the condyle, as seen here in the clinical pic, and this is how the buttonholing of the condyle through the capsule occurs. They call it as type 5, and they advocate it to be managed operatively. Now, management of acute injuries of MCL. So what are the options we have? So non-surgical options and surgical options. And what does the literature say about this? And if at all, if it's non-surgical management, how do you manage it? And if it's surgical manage, how do we manage it? We will try to answer some of the questions. In this article by Carlos and co, they defined a tabular column to guide us with regards to management of MCL injury. They suggested that if there is isolated injury, grade 1 and grade 2 American Medical Association, they advocated conservative management, and grade 3, if varus alignment or normal, they still advocated conservative management. And if valgus or some MCL entrapment features will be discussing in further slides, and those kind of exclusive bony avulsions or Steiner lesions, those have to be managed with acute repair. Another subset which the author classified is combined MCL and ACL injuries, where there are 3 schools of thoughts with the conservative management of MCL and delayed ACL reconstruction, early MCL reconstruction with conservative management of MCL. This is what we follow in our institution, and early ACL reconstruction and MCL repair. Coming to some literature review about conservative management of MCL way back in 1981. Since then, Garrick and co, they evaluated 70 knees and with grade 1 and grade 2 MCL injuries. And in grade 1 injury patients, they returned to sport only in 10 days, and grade 2 returned to sport in 20 days, as suggested in this article published in AJSM. So this signifies that MCL was managed conservatively since long. And in this article by Farzad and co, where they reviewed the current concepts and management in MCL injuries, they suggested one article, they mentioned one article by Halinen again, where MCL non-operative management was more or less had similar results when they were managed operatively and non-operative management. Same author again concluded, did another study where they said that MCL non-operative management was associated with better knee function in first 9 months post-operatively. The same author in their article mentioned about the operative indications of MCL, which we should be concentrating upon, and we should keep this in mind. They divided the indications of MCL repair, operative management of MCL repair, into 2 subheadings: history and clinical examination indications and radiological indications. Open MCL injuries, medial knee laxity with varus stress, and Ambry multiple ligament knee injuries, and then chronic MCL tears, which are treated conservatively but which had instability symptoms. And radiological indications would be valgus malalignment, tibia plateau fracture, Steiner type lesion. Steiner type lesion is nothing but the attachment of the distal part of MCL comes above the pes structures, so that it's hindering the healing process. Large bony avulsions or entrapment of the MCL intraarticularly. So these are some peculiar indications which, without a second thought, we would think about operative management as per this article. So after defining some answers to the questions asked, we'll be going further with how, if at all, non-operative management is done, and what are some key points we should keep in mind. In this article by Laprade, published in Journal of Orthopedics and Sport Physical Therapy, they defined a protocol for conservative management of MCL. They divided it into 4 phases, where first phase was for 1 to 2 weeks, where they stressed upon cryo, weight bearing as tolerated, and knee bending as tolerated. But they advocated use of hinge knee brace, which would provide sagittal plane stability. Phase 2 was continuing of the same, but progressive isokinetics and step-ups were done. Phase 3, for about 5 weeks, hinge knee brace has to be continued for totally 6 weeks, and crutch has to be started weaning off from this time. At the end of 6 weeks, there should not be any crutch. Strengthening, sport-specific exercises and gait correction has to be done. So if it's confusing, to make it short, hinge knee brace is what the author advocated, and achieving 90-degree in the initial 1 month is what has to be kept in mind when conservatively managing MCL. This is operative management of MCL, where in this article published in 2018, distal knee MCL repair with suture anchors by Trofa and Co. They, in their article, suggested that bony avulsion should always be fixed and it should be operatively managed, and with after proper indications have been defined and MCL is decided to be repaired. So this surgery is divided into two parts, where MCL repair is initially done and it is augmented with suture tape. Here, this is what they approach, and MCL being taken up and fixed with the suture anchor as shown in the picture. They further extended the procedure with attachment of fiber tape in the femoral attachment and augmenting. And this fixation was more or less like how we fix MPFL in our institution. Like, it should not be over tightened, and there is a counter kept to check the over tightening of the augment as shown in this picture, and also the isometry how we check, and this is how the isometry is checked by the authors in this particular procedure. Another article by James and Co. Posteromedial corner injury, knee dislocation. They concluded that isolated MCL repairs had a failure rate of 20%, and augmentation of that would decrease the failure rate up to 4%, which was significant. Coming to the MCL reconstruction part, in this article by Prince and Co, they defined some indications and contraindications for MCL reconstruction. They said multiligamentous knee injury and injury to the associated structures, valgus instability, and they said that the contraindications are isolated MCL injuries which had the potential to heal by conservative management. This is what we should keep in mind while approaching MCL injury. The concept of reconstruction of the MCL started way back in 1952 by Bosworth, where he transplanted the semi-T for the repair of the laceration of the MCL of knee, published in JBJS in 1952. And this is one part, although we did not retrieve the original article of Bosworth, but it's mentioned in other articles as shown in the schematic representation, where distal part of semi-T is attached, and it is detached from his muscular tendinous junction, and proximally it is attached to the femoral end as shown in the picture. And extension to this Bosworth technique was done and modified and called it as modified Bosworth technique, where distal attachment is same and the first process is repeated with femoral attachment being done by doubling the semi-T at the isometric point at its proximal extent, and extending that graft down, and then reconstructing the POL as shown in the picture. So here the superficial and MCL, superficial and deep fibers of the MCL were reconstructed along with the POL. This is known as the modified Bosworth technique. Some other techniques are also defined, but not so popular. Kim's technique, where similar semi-tendinous semi-T tendon is left intact distally and proximally stripped from muscular tendinous junction. Proximally, it is fixed at the femoral the femoral isometric point, and the extension of it is attached to the semi-tendinosus tendon. This is known as Kim's technique, and this was again further modified as Stannard's technique or modified Kim's technique, where without attaching it to the semi-tendinous semi-membranosus tendon, it is attached to the attachment of the same tendon. In this article by Reha and Co, they defined, though it's mentioned in many articles, this is one of them. They defined the reconstruction of the MCL by three principles. One is single bundle reconstruction as shown here. Two is double bundle reconstruction but non-anatomical, and three is double bundle reconstruction anatomical. First is the single bundle reconstruction as defined by Yoshia in this article by MCL reconstruction using autologous hamstring tendon. This is more like harvesting the hamstring graft as we do for ACL, and then reconstructing the same through isometric points as shown in the picture with fixation as defined in this picture with suspensory fixation distally and aperture fixation proximally. This is from their original article. Watson, they also defined one technique where they use suspensory fixation for both the side reconstructions as defined in this picture. Another popular reconstruction method was Lind's method, where the distal extent of hamstring is left intact and the graft isometric point is identified on the femur, and it's doubled and the aperture fixation is done at that point, and the POL reconstruction is done from posteromedial to anteromedial tunnel in the tibia. So this is the schematic representation and the clinical representation in the article mentioned in Lind. Another popular reconstruction method is defined by Leprad. Leprad is of the opinion that the isometric points should be at the anatomical position, not at the hamstring attachment. So this is free graft from hamstrings, and anatomical double bundle reconstruction is done as shown in this picture, that POL from its point in relation to the gastrotubercle and the capsule extension of the semimembranosus is identified and POL is reconstructed, and MCL is reconstructed with proximally at its attachment in relation to the medial epicondyle proximally and superior to it, and then 6 centimeter distal to the MCL. This is basically reconstructing the superficial MCL, and this is the clinical picture defined in the Laprad's article, and this schematic representation of the same. Another technique defined by Amit Joshi, weaver's technique. Basically, this is not too different, but they weaved the harvested semi-T and they weaved it through the substance of the MCL as shown in this picture, and then taken out and passed on to the proximal side attached, and then the same is turned down to reconstruct the POL. If it's confusing, then we can see the schematic representation how the proximal muscular tendinous detachment is done and weaved through the MCL, the remnant of the MCL, and proximally taken up and then fixed at the femur and then taken down to reconstruct the POL. Comparing this weaver's technique, Amit Joshi's technique with the other techniques, Laprad's is what the double bundle anatomical reconstruction, and this is how the it is weaved and then extended to the POL reconstruction. Though they have mentioned some pearls and pitfalls of the same, weaver technique provides more anatomical superficial MCL reconstruction and better outcome as per the author, but there are certain shortfalls of it. A deep MCL is not constructed. Somebody who's having thin and short semi-T would not be suitable candidates for this kind of reconstruction. Coming to the other concepts of MCL reconstruction is by using allografts as defined by Robert. They used tendo-Achilles allografts for the same, and they suggested that this study was done in 24 patients, and they concluded that this provides a favorable clinical outcome in this kind of patients. Other modifications is using BioBrace synthetic collagen-rich synthetic material. The principle of this material is that it provides a biological media for the generation of the tissue in the medial side to give stability. And this is fixed as fixed any other tissue with suture anchors. And this is the BioBrace as mentioned in this article. And this is the final reconstruction image of the same, though that's not so popular, and the author suggested that this would provide a promising result in the future. Coming to some biomechanics of the reconstruction of MCL reconstruction. In this article by MCL reconstruction, graft isometry is affected more by femur position than by tibia position, published in Casta by Christoph. They concluded that reconstruction by hamstring-based distally attached graft does not change the biomechanical properties of the graft as much as that would have if the isometry is not achieved at the femur side. And they also concluded that POL reconstruction should always be fixed in extension. As we can see in this schematic representation, this is the normal superficial and deep MCL and the extent of the POL as shown in the picture. After various methods, be lens procedure or Laprade procedure, they suggested that the movement of the knee pivots around the tibial attachment, and this is where the excessive stresses happen. So a minute change in the isometric point of the femoral attachment will have a rampant different biomechanical effect on the graft. So they advocated that taking an anatomical reconstruction or the distally attached hamstring reconstruction does not have much difference until and unless the isometric point is achieved as near as possible to the original attachment of the MCL. Some take-home message. In acute scenarios, isolated MCL injuries, grade 1 and 2 can be managed conservatively. Grade 3, debatable. If it's varus and normal alignment, can be again conservatively managed. And if it's varus alignment or MCL entrapment or bony avulsion, as mentioned earlier, it should be acutely repaired. MCL injuries with ACL is again controversial. Some advocate early ACL reconstruction and then MCL repair. Some advocate ACL reconstruction is conservative management. Some wait and watch for MCL healing and then reconstruction ACL at a later stage. In multiligamentous scenarios, MCL is most commonly repaired, but it can sometimes like some advocate it to be conservatively managed and then the delayed ACL PCL reconstruction. MCL repair and the PCL reconstruction and delayed PCL reconstruction are addressing all the three ligaments at once. In chronic scenarios, valgus stability has to be assessed. If valgus alignment is there, then varus distal femoral osteotomy has to be considered, and normal or varus alignment reconstruction, MCL reconstruction or allograft reconstruction can be done, but most commonly MCL reconstruction by autografts, as explained, is considered. In chronic scenarios, if there is valgus instability with ACL reconstructions, MCL reconstruction plus or minus augmentation needs to be done at a later stage before after addressing ACL reconstruction. So if at all, if acute repair is indicated, time of surgery is important because it's difficult to primarily repair at a later stage. So timing is important, we should keep in mind. And if at all we have some suboptimal repair in top, we should consider augmentation. It has to be planned beforehand. Distally attached based hamstring reconstruction are good options as mentioned in the biomechanical studies. Laprade's technique is biomechanically more stable because it addresses the anatomical points while reconstruction, and further studies has to be done on the same. Allografts and synthetic grafts, as mentioned in the article, they have not become popular, and further studies are needed until unless we follow the same. Thank you.
Master, it's a wide topic, well covered in a short duration. You've covered all the points which is required. Your take-home message was complete. Only one thing which I would like to add is in a chronic setting, did you come across any kind of those capsular procedures? Did you elaborate on that?
No, sir. I was mostly speaking on MCL.
So what do you? Yeah, MCL in this chart, flow chart, the right side second box. Can you see capsular procedures?
Yes, yes.
Can you point that out?
Yes.
So in the chronic setting, there is something called the capsular procedures. So
Yes,
what do you think it is? Did you come across? Mas?
So,
So in a chronic setting, one you said about osteotomy, all the rest you covered. The capsular procedures, did you understand that, or anybody else know about this?
sir, I'm unable to hear you, sir.
You're not able to hear me. Sorry. The capsular procedures. What exactly are those capsular procedures?
Yes,
Capsule.
sir.
What are the capsular procedures? Am I audible?
Voice getting stuck, sir.
Yeah, you're well audible, Santosh.
Okay.
The
So other
capsular-
fellows, what are the capsular procedures? Any other fellows can answer this? Okay.
We can do a reefing of the tightening of the capsule.
Yeah, you must exactly. So in an acute situation, all the MCL will be torn. In a chronic situation, all the MCL structures would have healed, but an entire medial sleeve of structures would have healed in a lax position. So, so when you just do a reconstruction, your entire force is going to be on the reconstructed tendon, graft. So capsular procedures are the ones which tighten the native MCL because the MCL is lax. When you do the medial opening, you can see the entire medial structures kinking and becoming flabby. So with that, you will be able to know where exactly it is loose. You can actually tighten it by cutting it and double breasting it. It can be done proximal to distal or posterior to anterior, depending on where the laxity is. So in description, you usually describe a double breasting posterior over the anterior, which tightens the POL and superficial MCL. It can be done um, proximal and distal also, which is more anterior fibers usually get lax when they open out in flexion. So the capsular procedure is also very, very important to tighten the native structures. Or when this procedure is done, you have to elevate the entire medial structures. Like when we do an osteotomy, HTO, we elevate the entire medial structures of the bone. Similar to that, we have to elevate the entire structure, then tighten it, double breast it, and then add an augmentation or a reconstruction. It's called augmentation because you do it along with the capsular tightening. Rather than doing just an MCL reconstruction, I would always prefer to do a capsular procedure along with augmentation because you're tightening the native MCL, which heals onto the bone, which is more robust than the reconstruction alone. So you have to be aware of the capsular procedures in chronic setting. So always freshen the capsule and tightening is what I would advocate rather than doing a reconstruction alone. I mean, which may be in a subacute situation, it might be helpful, but in a chronic situation, you have to add a capsular procedure. Apart from this point,
Santosh,
so
may I throw my 2 cents in?
sure, sir.
The MCL has a deep and a superficial part. Sometimes the deep is torn and the superficial is stretched. And you can test that by laxity in extension as compared to laxity in flexion when superficial and deep are both torn. Years ago, they had described a procedure called the MAUCK, M-A-U-C-K procedure, which is really a capsular reconstruction by raising an osteoperiosteal flap and putting the original ligament underneath and stapling it. And I have done that in my training program because at that time, some of the newer techniques were not available. MAUCK procedure, the fellows can look it up, and that's a capsular reconstruction. It's capsular reefing, like Amar said.
How are the results of those procedures, sir?
Well, those days we thought everything was good. You know, people never report your bad results.
We've done few
So-
cases which actually are robust and heal really well with these chronic.
Yes, if the patient is young and have had a chronic laxity and the capsular part or the deeper collateral ligament is stretched or torn or both, they really work well. And you can test it in extension on the operating table. We used a metallic staple those days to put the osteoperiosteal flap back.
They didn't have the suture anchor then. So they
No.
used to use a staple, yeah. Yeah, a lot of importance
Right.
used to be given for capsule earlier. Now also relevant in the right places. Yeah.
We even used it in the shoulder, David, for putty-plat procedures.
Yeah. Sorry, I missed the first few slides. Did Mars emphasize the importance of tear the MCL proximally or distally, or a different topic altogether, already been covered?
Sir, I told that in the
No, you mentioned about conservative treatment, didn't you? And
Yes,
this
sir.
includes that also.
Yeah, he did.
The importance of the site of tear, is it femoral or tibial? The importance, did he highlight? I'm sorry, I missed that too. If he had already done it, it will skip and go. If he had not done it, Santosh can
No, he
less
did
quickly.
femoral side heals well compared with tibia, and both heal, but femoral heals better. That's the point sir wants to convey.
I thought tibial side doesn't heal so well, and you have to look at it surgically. No.
Not all tibia, sir. Tibia, stenus, even tibia heals. Femoral heals better than tibia. Tibia stenus do not heal. I mean, tibial sides, if there is interposition and if it's pulled off or folded, then surgical intervention is mandatory. But tibial side, there are mixed literatures. Tibial side, there are people who augment and repair all of them. We used to do that before, but now we're not doing that because tibial do heal.
Okay.
If it's in place, it's not moved away.
So this classification, like while the type 1 was pre-avulsion, like on the femoral side, this obviously conservative management, this is avulsion of the femur side. So here they mentioned that this has to be managed conservatively, though the proponents of operative management operate, but mostly conservative management only. So type 2, this management prospective classification, and again mid substance, the conservative management, and some would operate surgically, they told, but conservative management till type 3, and type 4 and 5 operative management. That is what was mentioned here, depending upon the site of
I would like to all the fellows who are not in our particular unit to see that medical student has been admitted. Examine him, look at the MRI, and so relevant to the talk today.
Yes, sir. Yes.
What's the name of that patient?
So,
Rahul, Arun.
If I'm not wrong, it's Sanjay, sir.
Yeah, okay, thank you.
Good morning, everyone. Am I audible? Are my slides visible?
Yeah, please go on.
Good morning, everyone. My topic is the multiligamentous injuries, timing, sequence, and fixation. The multiligamentous injuries, they're defined as injury to 2 or more of the 4 major ligaments. That is the ACL, PCL, the posterior middle corner, and the posterolateral corner ligaments. Any 2 out of these 4 major ligaments is called as a multiligamentous injury. Mechanism of injury ranges from a high energy trauma like a motor vehicle accident or a fall from height to low energy traumas called sports injuries, or ultra low energy traumas, especially in obese individuals. It's a rare injury. The classification was given by Schenk et al. And it's called as a KD classification. Type 1 is where dislocation includes a disruption of either of the cruciate ligaments. Type 2 is when dislocation with both cruciate ligaments. KD3 is dislocation with the cruciate ligaments plus either MCL or LCL, which can be further divided into 3M and 3L based on whether the medial side or the lateral side is injured. Then KD4 is dislocation of both the ligaments and both the collaterals, and KD5 is fracture dislocation. One drawback is that it does not include the trauma to the soft tissue envelope extensor mechanism and other injuries which can decide the prognosis of the multiligamentous injury. So when a multiligamentous injury patient comes to us, or a suspected multiligamentous injury comes to us, what should be the emergency room protocol? First of all high velocity injuries, knee injuries should be suspected to have a multiligamentous injury, because many times they will come with spontaneous reduction. So we should examine carefully. In case it's a dislocated patient comes to the ER, then it should be carefully repositioned, and it should be before attempting any formal reduction or repositioning, we should get a radiograph. That is very important. Unless this is severely compromising the soft tissue envelope. For example, there is it's tenting on the skin or about to pierce the skin, then we can attempt a gentle repositioning before an X-ray. Checking the vascularity and neurological status is paramount, and as I said, X-ray is very important. So how to reduce it? Based on the radiograph and the direction of dislocation, there are different maneuvers. Preferably, they should be done under anesthesia, and after reduction to test for the ligamentous injury. We can do different tests, but care should be taken that only the tests which involve minor knee manipulation, like the varus and valgus test or the Lachman test, should be done, and we should not do tests that involve greater knee manipulation, like the posterolateral drawer or the pivot shift test, which can cause further damage. So when we have received the patient, we have done the reduction, what should be the protocol after that? First and foremost is a post-reduction X-ray should be done. Then we can do an MRI or CT to assess the degree of damage. Stress radiography in select cases, and most important, to see the distal pulses in the ABPI for first 72 hours. Examining the distal pulses is very important because they're seldom associated with they're often associated with the neurovascular injury. So this is a paper by S.T. Saroyar from University of Pittsburgh. They basically gave a protocol of management of acute knee dislocation. They mentioned that in case there is no indication for an emergency surgery, it can be the multiligamentous injury can be immobilized in few knee extension, full extension in a brace for some time before a plan is made, unless there is an emergency intervention. So one of these emergency intervention is a knee dislocation or a multiligamentous injury with a vascular injury. So this is the protocol that we should follow if we are suspecting a vascular injury. After the reduction, we should check the perfusion, if it's well perfused or whether it's still ischemic. If the limb is well perfused and pulse is present, then we have to check the ABPI, whether it's more than 0.9 or less than 0.9. If the pulse is absent, then we have to straight away go for a CT angio. And even if the pulse is present, but the ABPI is less than 0.9, again, we have to go for a CT angio. In case of ischemic limb, we have to directly plan for the exploration of the vessel. So this is an image showing a popliteal artery injury in a CT angio and a repair being performed. Other cases of emergency management of multiligamentous injury are cases with the compartment syndrome, cases with open dislocation, and cases grossly unstable fracture dislocations. So when we receive a patient with acute MLK, multiligamentous injury, which doesn't need an emergency intervention, there are three ways where how it can be dealt with. It can be either repaired in a single stage with repair of collateral, repair or reconstruction of collateral and cruciate ligaments. We can do a stage ligament surgery where in an acute phase, we can do a repair and augmentation of the collaterals, followed by subsequent second stage reconstruction of the cruciate ligaments. Or we can do an acute phase immobilization, then followed by a delayed reconstruction. Again, the delayed reconstruction can be a single stage or a double stage process. So there has been a lot of controversy going on in the past regarding whether they should be repaired early or late. This paper in 2009 by Bruce A. Levy et al. They basically did a systematic review. They reviewed 5 studies and they found out that patients undergoing surgery within 3 weeks have shown a higher return to sports as compared to others who underwent a surgery more than that. The reason that they gave was that after 3 weeks, the soft tissue planes are lost and there's a lot of fibers and it's difficult the anatomy becomes difficult. Another study came in 2017. They basically reviewed 8 studies. 149 patients were treated early and 11 late. And they again found out that early surgical intervention produces a better clinical outcome. This paper was from India. They did a stage reconstructive surgery. Here what they did was, they did in 3 stages. In first stage, if it's a stage 1, grade 1 or 2 collateral ligament injury, they manage it conservatively. Whether if it was a grade 3, they did a primary repair. Then in second stage, they did a ACL reconstruction if it was only ACL. But if it had ACL and PCL, they reconstructed the PCL first, and then again waited. And if the patients had no symptoms of instability, then they continued with it and didn't do an ACL reconstruction. They did this for 21 patients. They have a data of 21 patients, and out of those 21, 6 did not require ACL reconstruction. Another paper came in 2014. This was from Wu Jiang and group. They found out that 79% of patients who underwent a stage treatment had good results, whereas a simultaneous treatment, acute cases only about 60% and chronic cases 45% had good results. So they were kind of favoring the stage treatment. Now, this is the latest of the papers. It came out in 2019 from Leprard group. In this, they recommend that a single stage reconstruction with an immediate rehab has shown a significant improvement in ligament in return to sports pattern in sports person. Now, what are the proponents? How early should it be done? The authors there is a lot of controversy still, but most of the authors have reached a conclusion that the repair should be done between 2 to 3 weeks. The reason for that is if done too early, because of the soft tissue injury and collateral injury, there can be a lot of fluid extravasation and the surgery becomes really difficult. Whereas if you give it 2 to 3 weeks, between 2 to 3 weeks, the collaterals might heal and then subsequently surgery becomes easy. And not to it more than 3 weeks again, because the soft tissue planes become difficult to delineate. Now coming to the chronic multiligamentous injury. So in a chronic scenario, we are again faced with 3 situations. First is a chronic ligamentous injury with a reduced knee. Second is a chronic situation with an unreduced knee. A reduced knee again can be divided into 2 groups. It can be either associated with malalignment or no malalignment. If there is no malalignment, then we can manage it again with a multiple ligament reconstruction, single or stage, depending on the surgeon preference. And if it has a malalignment, then the first focus should be correction of that malalignment with or without tibial slope modification. And then we should focus on the ligamentous reconstruction. Whereas if it is unreduced, then we have to do an open reduction, put a hinge fixator, and then do a ligamentous reconstruction, either in the same stage or in the later stage. Now, why to correct a deformity is important. This was a paper that came out in 2007. They said that in 21, they had a caseload of 21 with combined PLC deficiency plus varus deformity. And they showed that in 8 out of 21 patients, An osteotomy alone was sufficient, and a subsequent PLC reconstruction was not needed. So the osteotomy alone was able to compensate for the instability, and patient was improving, and his knee function improved. The reason is that if we do a reconstruction without doing an osteotomy, there is unparalleled load on the graft, and it will eventually fail. And it has been shown in the conclusion they mentioned that patients with low velocity injuries and isolated PLC injury may not require a surgery if the osteotomy has healed properly and he has underwent a program of rehabilitation. Now, this paper in 2004 by Robert Griffin, he highlighted the importance of tibial slope on biomechanics of the knee. And he showed that an increase in tibial slope causes significant anterior translation of the tibia under axial compression. So this can be better explained with this diagram. So if we increase the tibial slope, it will reduce a tibial sag. So basically increasing tibial slope will be helpful in a PCL deficient knee, as seen in the diagram on the right. And where if we do a decrease in tibial slope, it will have a reverse effect. It will have a protective effect on the ACL graft and will cause a posterior translation of the tibia. Now, when we are faced with a multiligamentous injury, one of the important questions is how to select the graft. Again, this question depends on which area we are practicing, and do we have access to allografts or not. In the West, mostly they are using a mixture of autograft and allograft, or allografts alone. But in India, we are using mostly autografts. So different grafts that can be used, and each has its advantages and disadvantages. The advantage of hamstring is that they have adequate length and can be quadrupled to increase the diameter. BTB has an advantage, can be used in ACL and PCL, as an advantage of a robust fixation, and same as quadriceps tendon. And then come the allograft. The advantage of hamstring is that they can be used in multiple ligament situation, and mostly in India for the collaterals and for the corners, we use the hamstring grafts. Now, the third group in a chronic situation, that is the chronic unreduced dislocation. As I already mentioned, the treatment for this is open reduction, a hinge external fixation, and stage ligament plus minus stage ligament reconstruction means can be either dealt at the same setting, or we can wait and for soft tissue healing, and then we can do ligament reconstruction. Important factor in this is a complete circumferential release and a scar tissue excision. This is a hinge fixator that can be used. So hinge fixator, apart from this chronic unreduced dislocation, has also been propagated in acute dislocations and in multiligamentous injuries, which are not chronically unreduced. So this was a paper that came in JBGS. They have mentioned that they basically supplemented, they compared the usage of a hinge fixator with a brace in cases of knee dislocation, this multiligamentous reconstruction. And they found out that the cases with in which this supplemented the reconstruction with the hinge fixator had less failed reconstruction as compared to external braces, though the braces were not advanced at that time, and also the fixator has its own disadvantages of the pin tracts, of contracture in the quadricep muscles, as well as risk of interfering with the future tunnels. So after making a plan, there are certain principles that we have to keep in mind before we go on for a surgery. The important principles are, we should have a comprehensive knowledge of the anatomy and biomechanics. Surgical planning should be perfect. There should be a close post-op monitoring, and we should have a phased rehab program in mind. The broad points of technique are that the tibial and femoral tunnels are reamed first, and for anatomical double bundle and single bundle ACL, then the chondral and meniscal lesions are addressed, and then open approaches to the posterolateral and the posterior middle corner. And finally, the cruciate followed by the collaterals are passed. So when we are faced with such a situation, one of the most important complications that can happen is a tunnel convergence, because of so many tunnels that are drilled in the femur and tibia. There can be a tunnel convergence which can cause a failure of the surgery. So this is a important review paper by Gilbert Moche, He basically authored 2 papers in 2016 in where he gave tips to avoid convergence in femur and tibia. And then he came up with this paper in 2018 where he combined those 2 papers and gave a complete analysis of how to prevent this tunnel convergence. So what he said was, when we are drilling the MCL tunnel, we have to be 40-degree proximal and 20 to 40-degree anterior in order to prevent the convergence with an MCL tunnel. And when we are drilling the tunnel for the POL, we should be 20-degree proximal, 20-degree anterior. Coming on the lateral side, he said that the FCL and the popliteal tendon tunnel should be 40-degree anteriorly, and this reduces the risk of conversion with the ACL tunnel. Coming to the tibia, he said that the POL tunnel should be 15-degree medial to the Gerdy's tubercle. And if it's yellow, that it's aimed closer to the Gerdy's tubercle, it has chances to converge with the PCL tunnel that is highlighted in green. And on the medial side, he said that if we aim the MCL tunnel transversely, it has a risk of converging with the PCL tunnel. It should be aimed distally, about 30 degrees. So in summary, in a combined PCL-MCL reconstruction, the POL should be aimed 15-degree medial to Gerdy's and MCL aimed 30-degree distally. Whereas in a combined ACL-PLC reconstruction, a 40-degree angulation in the axial plane and 0 degree in the coronal plane should be done while doing an LCL and popliteal tendon reconstruction. And again, if you are in doubt, we can always use a C-arm. So we have our own techniques to prevent conversion, and we don't use multiple tunnels, and we have something called as a convergent tunnel, a single tunnel technique, where we use the same tunnels for the ACL and the LCL, and then for the PCL and for the MCL, and we can continue the same graft over the endo button. We take a semi-tendinous graft, hamstring graft, for constructing the PCL, and then it has gracilis along with it, and then after looping the endo button at the femoral condyle, the gracilis graft is continued, and it continues as the MCL. In the same way we do it for ACL and LCL as well. Another important question after passing the grafts is that how the graft should be tensioned. So this paper by Dr. Dinsha Patiwala came in 2017. He gave this following sequence of passage of grafts. The most important point in this that the PCL double bundle grafts are fixed on the femur and tibia first. The importance of this is that PCL forms the central pivot in the knee. So before tightening any other grafts, we should secure the PCL grafts. And this again, I'll tell later, that this again is a point why the staged reconstruction is slowly going out of fashion, and now a single stage multiligamentous reconstruction is the standard of care. So according to this sequence, PCL double bundle grafts are passed, then ACL single bundle grafts are passed and fixed with suspensory fixation. Then the PCL grafts are tightened on femur and tibia. After that, the PLC grafts are fixed. Then ACL is tensioned and fixed on tibia. And finally, the medial structures are fixed. So this is a paper that came in Journal of Bone and Joint Surgery. This highlighted the importance of PCL. This, as I told it, it is the central pillar of knee, and reducing and fixing the PCL reduces any step off, and which can cause a lag. For example, if you fix the collaterals before correcting the sag, then when the sag is finally corrected, the collaterals will become lax and eventually fail. So when the PCL is tightened, we should be careful that the anterolateral bundle should be tightened at 90 degree and posterior medial at 0 degree. But if you're doing a single bundle, which is done less, we have to tighten it at 90 degree. As I already told, the next is PLC. Now, why PLC is next? Because if we fix the ACL before the PLC, there is some amount of tibial external rotation. So this study has shown that in PLC deficient knee, if ACL is tightened, there is increased tibial external rotation. So the PLC has to be fixed first, and then we go on to the ACL. And it's fixed in 30 degree tension and 30 degree of flexion, and then finally MCL and POL are tension. MCL is tension in 30-degree of flexion, whereas POL is tension in full extension. The next and an important step is the rehabilitation. The rehabilitation is a core of any orthopedic surgery, and more so in the multiligamentous injury. And this paper came out in 2017, and they showed that early mobilization in an acute MLKI had better range of motion and stability. And what they they basically recommended is an initial period of non-weight bearing, then followed by active mobilization, progressive weight bearing. And this is very similar to what we follow here, which Mr. Paul will explain in some time. So the gross features were that till 8 weeks, there were no active hamstring contraction for PCL, and there was only passive flexion with support to the posterior tibia till 6 weeks. And for the integrity of the PLC, extension was limited to 0 degree. No hyperextension was allowed because it can cause stretching. And as Dr. Mars also said, MCL any valgus force on the knee joint is provided. So this is an important brace called as the OSO brace, and this is an important brace in a rehabilitation protocol. It basically gives a physiologically dynamic force to the proximal to the tibia. It prevents the sagging, and this load is generated by applying an anteriorly directed force in the calf area, and it has a counterweight on the anterior aspect of the leg. So the take-home message from the entire talk is we should always have a high index of suspicion for the neurovascular injuries. Early treatment between 2 to 3 weeks gives good results. Single stage management is better than stage management in sports injury. Malalignment should always be corrected before going on to ligament reconstruction in a chronic multiligamentous injury. Steps should be taken to prevent tunnel convergence, and we can use a single tunnel technique as we use. And proper sequence while tightening and fixation should be followed, and a guided rehabilitation program must be followed. Thank you, sir.
Thank you, Amar. Again, it is well covered regarding the sequence and tunnel convergence. I mean, in a multi-ligament situation, trying to address all the ligaments at one shot is technically challenging. So to begin with, if it is difficult, no harm in doing it staged, where you only thing you have to make sure is you correct the sag before you address the collaterals. So if at all you want to do it staged, do PCL and collaterals in one stage and the rest in the next stage. If it's really acute, you won't be able to do the PCL, then you have to do ways to, if the MCL is badly torn, like in Steener's lesion, you cannot go in late. You have to go in early. So in those situations, you go address the MCL, but make sure you do something like an X-fix or a good brace where you keep it corrected in the sag is in a corrected position. In certain situations where there are avulsion fractures, you have to go in acute. If you are able in an MCL, bad MCL with an PCL avulsion, sometimes you might be able to do it open, where you open out the medial side, your entire MCL will be ripped off. So you can do an open PCL avulsion fixation or an open PCL reconstruction, because you can reach the posterior structures through the open MCL. If the MCL is intact, it will be difficult to reach there. When the MCL is totally torn, it will be easy to reach, and you can do an open PCL through the medial approach. In those situations, you can just address the PCL in an open manner and then repair the MCL or reconstruct the MCL and come out. Then do the rest in stage 2. But in stage 1, addressing whatever meniscus, if it are not small tears, but the bucket handle tears or flipped meniscus must be put back in place. Maybe 1 or 2 sutures also will help, because you're not going to mobilize the patient a lot. So to begin with, staged reconstruction is okay. But as you gain the technical skill, then your support team and your OT environment and your armamentarium must be there to do all of them in one stage. If not, no harm in doing it into stage rather than harming the patient. So So even though literature and you see here everything done in one stage, two stage, it is not a problem. We also do two stage in certain situations, like you would have seen in avulsion situations, where you address the avulsions early and do the rest later. Sometimes PCL might heal on its own. You might not do stage 2 later on. So all options are open. It's not always one route which you take.
Thank you, sir.
Sir, your point, sir.
Now you have to counsel the patient properly. Very, very important, because you cannot give the patient 100% normal need. That's very, very important. Otherwise, even if you do an excellent job, in your opinion, your patient will be very, very unsatisfied. Then, as Dr. Santosh mentioned, very often we find that the PCL reconstruction and the other side reconstruction, collateral, and in a non-athlete, the ACL reconstruction becomes unnecessary. So there is a point which you have to bear in mind. The vascularity and injury and all that has been emphasized. You have to be aware of all that. So I don't know how many of you know that there's a handheld Doppler in the emergency. Anybody who doesn't know?
Yes, sir.
Please. Yeah, okay, good. Right. Don't hesitate to use it. Thank you.
Thank you, sir.
So good morning, sir. Am I audible?
Yeah, Paul. Slides are visible.
Visible. Okay. So good morning, everyone. Today I'll be talking about the post-operative rehabilitation after PCL reconstruction. The phases of rehab, there are 6 stages. First one is protective phase. The second one is optimal protection and mobility, ROM. And the third phase is strengthening phase. And the fourth one is proprioception and balance. And fifth is agility and plyometrics. And the sixth phase is sport-specific phase. There was a paper published in the International Journal of Sports Physical Therapy. It's about a literature review of published protocols. The purpose of this review was to gather the literature related to PCL rehabilitation and summarize the current rehabilitation guidelines. From this study, we get to know about the details regarding the weight-bearing status, the knee range of motion, the brace usage, specific exercise recommendation and suggestions for return to sport. These were summarized in this study. So in my today's talk, I'll be comparing our protocol with this study. First is about the post-operative weight-bearing status. Out of 44 studies included in this paper, 35 studies have given recommendation regarding the post-operative weight-bearing status. The 12 studies recommended non-weight bearing ranging from 2 weeks to 8 weeks. And 4 studies recommended toe touch weight bearing duration ranging from 10 days to 6 weeks. And 14 studies recommended partial weight bearing ranging from 20 to 80% and gradually progress to full weight bearing. And 6 studies recommended full weight bearing or weight bearing to tolerance. And in the protocol which we follow, it is non-weight bearing for 6 weeks, followed by partial weight bearing in the 7th and 8th week. And regarding the range of motion, 35 studies have given some recommendation, in which 19 studies fall under early range of motion group, in which 2 studies recommend unrestricted range of motion, and 13 studies recommended range of motion from 0 to 90 degree and gradually progress above 90 degree after 2 to 10 weeks. And 2 studies suggested or recommended early protective but full range of motion. And only 2 studies we can get the details about the prone range of motion. And in delayed range of motion group, there were 16 studies And in these studies, the range of motion exercises started only after 2 to 6 weeks. In the protocol which we follow, we start passive prone knee bending exercise, only passive prone knee bending exercise after the second wave. After suture removal, we start passive prone knee bending with hinged knee brace. And supine knee bending will be started after 3rd to 4th week, and high sitting range of motion will be starting after 5th or 6th week. And the goal to achieve 90-degree is by the end of 8th week. Next, about the post-operative bracing, 42 studies have given some recommendation, in which 30 studies recommend the knee has to be immobilized in extension knee brace. It is just a long knee brace. And only 4 studies provide details about unlocking and range of motion. And the time frame to discontinue brace according to these papers is 8 to 12 weeks. And according to our protocol, initial 2 weeks we give long knee brace with posterior tibial support, and that's for 2 weeks. And after 2 weeks, we shift them to we give them a hinged motion control knee brace, and that has to be worn from second week till 4 to 6 months. And regarding the strengthening exercise, most of the studies they recommend in the initial phase co-contraction exercise of quadriceps and hamstring. Example, mini squat, short arc, leg presses. And this has to be progressed to isolated quadriceps exercise, and isolated hamstring strengthening exercises has to be delayed because it has a negative impact on the graft. And there are a few studies which actually neglect or ignore isolated hamstring exercises till 6th month. About the return to sport, 36 studies have given some recommendation, in which 2 studies recommend 4 to 5 months for return to sport, and 7 studies 6 to 7 months, and 19 studies recommend 8 to 9 months for return to sport, and 4 studies 10 to 12 months for return to sport. In our protocol, it is after 12 months we allow them to participate in sports. Now, regarding the protocol, phase 1, that is day 1 to 8 weeks, our goal is to control pain and swelling, improve patella mobility, to improve range of motion up to 90 degrees, and maintain a good quadriceps control and monitor soft tissue contracture. So this is the brace which we give. The first one is a long knee brace with posterior tibial support to prevent the tibial sag. And the second one is the range of motion brace. This company is called Visco. Now we are not using it because there is a difficulty in fitting it to the patient. We are not getting small and X small sizes. Now we are using a brace called brace. And even in that, we are facing some difficulty because the straps in the brace is not of that good quality. We have already spoken to the company and they are working on it. As an alternative, we are using a Tynor brace now. And the bed mobility exercises, we start in the initial day 1, we start ankle toe movements, isometric quadriceps and hamstrings, followed by bridging, and crunches for abdominal muscles. Then 3-plane SLR, that is hip open chain exercises with leg knee extension. SLR abduction and extension is done. And this is the passive prone knee bending exercise. One hand is placed on the proximal calf muscle. A gentle pressure is applied to prevent the posterior translation of tibia, and gentle knee bending is performed. And once that is done, usually passive prone knee bending we start after 2 weeks, and supine knee bending we start after 3 to 4 weeks. First week, the range of motion is controlled to 30 degrees, followed by 45 to 60, then 60 to 90 degrees. Phase 2A, it is from 2 months to 4 months. Our criteria to progress is there should not be any flexion deformity. The range of motion should be 0 to 90 degrees at least, and there should be good quad control. And our goal is to correct the gait and start with strengthening exercise. So usually patient comes to us with antalgic gait, that is limping, or stiffening gait. In these patients, we have to activate the quadriceps muscle, improve range of motion, and in foot, we have to check for proper heel placement and proper takeoff that can correct the gait. And once that is done, from 2 months onwards, we can start with a resistance band hip open kinetic chain exercise for flexion, abduction, abductors, and extensors. And after 2 months, we can start with mini squats with support. And initially till 60 degrees and gradually progress to 90 degrees. Once this is comfortable, we can progress with leg press. Initially, it is done with a resistance band, but with the brace on. Once the patient is comfortable, we can progress to leg press on the machine. And phase 2B is 3 months to 5 months. Again, it's a strengthening phase. And criteria to progress is there should be a good and smooth range of motion, and there should be comfortable symmetrical bilateral loading. In this phase, we start unilateral exercises. Single leg strengthening exercises will be started. So we start with dumbbell squat, forward step up, and side step ups. Then followed by resistance band terminal extension to strengthen VMO and the quads. And weight shifting exercise, the initial balance training to load the operated leg. So forward and backward movement and lateral movements are performed. The athlete or the patient should be weight bearing on the operated leg. So once they are comfortable, single leg squatting is started, initially up to 60 degrees, then progress to 90 degrees, and initially with support, then without support. Once they are comfortable with doing the single leg squat without support, we can progress with weights. And after 5 months to 9 months, we can start with balance exercise, running drills, and plyometrics. So during this phase, we can use the technology which is available in our department, that is ISOMOVE for strength testing and training, and Prokeen to assess dynamic balance, and ISOShift to assess do a functional movement screening, and to assess static balance. So suggestions. There are no consensus regarding the rehab guidelines. Since our protocol is strong and we are getting good success with our protocol, we should try publishing our protocol also. And there are a lot of studies which recommend early weight bearing. So should we also consider early weight bearing, maybe by 4 weeks? And can we discontinue brace by 3 months? Now we are discontinuing brace by 4 to 6 months, and compliance is also very poor by 3 months. The patients come and ask to us if they can remove the brace or not. But we say they have to wear till 4 to 6 months. If it is safe, can we consider discontinuing brace by 3 months? And can we improve range of motion beyond 90 degree gradually after 4 months? Because even after 6 to 8 months, we have seen PCL patients coming with restricted range of motion, restricted to 90 degree or 100 degree. So if it is safe, so we should consider improving the range of motion beyond 90 degree gradually after 4 months. And in our protocol, we usually start isolated hamstring exercises in the gym along with isolated quads. So maybe we should delay the isolated hamstring exercises by 1 or 2 months. Thank you, sir.
Paul, go back. Thank you. Very good evidence-based. I mean, I wouldn't say it's evidence-based. Very good literature review. But all of these reviews are evidence-based, or it's just the protocols which they follow. But how successful is the protocol has not been tested, right?
Yeah, it is not tested, sir.
Okay, so we should be a little careful in adopting it. Can you go back to your previous slide for all the suggestions?
Yes, sir.
So weight bearing, what is your suggestion is to start by?
If it is isolated PCL, can we start little early, sir?
Yeah, 4 weeks is okay. But some avulsions, and depending on that intra stability, weight of the patient, we can actually start weight bearing early. That's not a problem actually. But associated injuries in a multi-ligament situation where MCL is torn, we cannot start. And then isolated, yes, we can start a little early.
Okay, sir.
Brace, 3 months is, yeah, okay, we can discontinue the brace. If it's an isolated PCL or PCL avulsion, we discontinue brace even earlier by 6 to 8 weeks. We discontinue if it's a bony avulsion. But even yesterday's one patient, I think Bal Subramaniam, somebody, the MCL 3 months over, the MCL is not yet healed. It's still opening inflection in 30 degrees. So he is heavy, he's 100 plus. So he's full weight bearing and walking. So in those patients, he would not listen to us. He would continue. He started riding two-wheeler. So for those patients, it's just a little more protection to have this RO brace.
Okay, sir.
But really compliant patients who have gained their strength sufficiently, if it's only the PCL, then we can discontinue the brace.
Okay, sir. So we should have a criteria.
Yeah,
If the knee is
patient to patient
stable.
it would vary. Correct. So it might vary from patient to patient. But
Yes,
on the
sir.
contrary, we've seen patients who, a doctor who had done a PCL alone,
Yes, sir.
he bought the Oxford brace and he was wearing the Oxford brace for 6 months. So if they're wearing an Oxford brace, you cannot say don't wear it. It's going to be
Yes, sir.
protective. And so we can discontinue brace in selected situations. Improving ROM, we do increase the ROM. We go past 90. But again, in the situations where MCL is not healed in a multi-ligament situation, not to push the ROM more than 90 if MCL is not yet healed, which
Okay,
might.
sir.
But in an isolated PCL, you have to do more than 90 by 6 weeks.
Yes, sir. Okay, sir.
What is the last point? Isolated core. What is the thing which we?
So isolated quad strengthening is leg extension exercise. Sorry, the isolated hamstring leg curl should be delayed. So leg extension and leg curls on the machine, we start on the same day. So most of the studies, they recommend starting this leg curl exercises in a later stage. So
PCL. For PCL, it's going to take the tibia back. Okay.
Yes, yes.
So when do we start this?
So we start by 4 months, and we start on the same day itself. Whenever we're starting isolated.
So 4 months for a leg curl is okay, but leg extensions can be started early on the other way.
Okay.
Probably that's what the literature says.
Yeah.
4 months is we were doing it already late only.
Okay, some studies they recommend starting after 6 months.
6 months.
They don't even train hamstrings till 6 months.
So Ganesh, sir.
Okay.
Sir, the hamstrings and the hip extension, both of the exercise in PCL we don't do in the initial 2 months, because when they do an extension also, there is going to be some amount of contraction coming from the hamstrings. So we have stopped the isometrics and the hip extension until the first 2 months. As Paul said, the hamstring strengthening we start delayed and patient is already having the brace And with the brace, even though if we can put it in 120°, the ideal range what we will get is just about 100 to 90. And we delay the hamstring until unless they don't get a very good quadriceps strength, we don't start the hamstrings. But in the long run, some of the cases when we have seen them in 1 year and 1.5 years, they have improved. But the first point, what Paul said, that the range is when they try to come and complain that can I bend it a little bit more or so.
Okay.
And the brace also, sir, sometimes in MCL and other co-associated soft tissues, we keep it for up to 4 months. And sometimes 3 months, if they have followed up things, 3rd month also it's been discarded. But I think we can have a consensus saying that at the 3rd month, we can take a call to see whether it is to be continued for 1 more month or that can be discarded.
Okay, so we'll stick to the protocol, but we'll keep it patient tailored. In isolated PCLs, we might start it a little early as suggested. Okay, thank you, Paul.
See, the very reason why we give the brace in 6 months is all patients start squatting the moment they can flex the knee around 90. The Muslim patients will start namaz the very moment they can get about 90. Earlier, long back, I used to have a lot of these issues. So that's why I started counseling them properly, no namaz for 1 year, 2 years or whatever, and then gave the brace for 6 months to just drive into the brain that this operation which cannot be taken lightly as far as rehab is concerned, you had to wait. That's why we had given brace for 6 months. Thank you.
Thank you, sir. So
Thank
we'll
you, sir.
stick to the protocol. Maybe in selected situation, we can shorten it.
Okay, sir. Thank you, sir.
Thank you, Paul.
That's all is over?
Praveen? So
Sir,
Praveen?
Praveen has
Is my screen visible, sir?
Yeah.
Yes. So I'll just be quickly running about the literature review we have. I mean, basically just a literature review regarding where we stand with regards to internal bracing in ACL, with regards to ACL repair as well as with ACL reconstruction. So internal bracing is a fairly new idea introduced as recent as 2015. This article by McKay et al. And following that, so there are only very few studies having regards to the clinical outcomes following ACL repairs and ACL reconstruction with internal bracing. So with regards to ACL repair internal bracing, this is the only review article I found with published in the Knee Journal by Wilson et al., including 9 studies and 347 patients. Again, the maximum mean follow-up in this review again is only up to 2.7 years. And I didn't come across any randomized control trials or meta-analysis for ACL reconstruction and bracing in any of the standard arthroscopy-related journals. So just quickly looking into this review. So these are the studies in this review where they included 9 studies. So again, if you look at the studies, the mean sample size around 30 patients, only 30 patients in each study. Maximum sample size are only 93 and 60 in 2 studies. Again, looking at the mean follow-up, the mean follow-up is only 2.7 years. The maximum data regarding follow-up we have is only for 5.7 years. That one just one study. And looking at the failure rates, it fairly varied failure rates, and average failure rates about 10.4%. So looking at the key results of this review, none of the studies are level 1 or level 2 studies. There are only 3 level 3 studies, rest are level 4 studies. No studies are blind or randomized. And all studies have mentioned reoperation rates were similar to ACL, and reoperation rates not necessarily meaning revision ACL with respect to other procedures like removal of hardware with subsequent irritation and other meniscal injuries. And with regards to the use of internal bracing in pediatric population, they are advocating a routine removal at 3 months to avoid any possible growth disturbance as per one study. And there are no objective difference in laxity with and without the use of internal bracing in ACL repair. As discussed, the data we have, which is the maximum available data as of now, is with 347 patients and a mean follow-up of only 2.7 years with regards to ACL repair and internal bracing. If you look at the failure rates, it's about 10.4% failure rate, just even at 2.7 years of follow-up. This is slightly higher than compared to standard ACL reconstruction failure rates. And the failure rate seems to increase with the younger age. In less than 18 years, failure rate has a 37%. And an interesting thing, point to note is that there's only one study with a follow-up of 5 years. If you look at the failure rate in that study, the failure rate is more than the average failure rate of about 16%. Point to be noted is that this is similar to the studies when ACL repair was initially tried in prior to 2000s, where the results were promising at the initial 2-year period. However, there were very poor results at midterm follow-up. So with that, revision rates were as high as 50% following repair. So the data regarding that aspect with following ACL repair internal bracing is not yet known. And also there's a lot of confounding factors, like most of the studies were from the innovators who are advocating and promoting the internal bracing device. And also there's not much documentation regarding return to sports following ACL repair internal bracing. So most of the studies, they advocate that can be considered as a viable option. Again, the reasons they put forward is the reasons for repair rather than the use of internal bracing. With respect to retained proprioception, no donor side morbidity, and easier ACL reconstruction in case of failures. And however, there are no studies documenting the delay as in chronicity of the tear and possible repair with internal bracing. So looking at the ACL reconstruction internal bracing, these are the commonly put forward reasons for an additional internal bracing in ACL reconstructions, particularly in ACL revisions and in patients with smaller grafts, particularly grafts of 8 mm or less. And while using allografts, particularly in young patients, since the time for integration allografts was a little longer than autografts, and in possible high risk for non-compliant patients. So I couldn't find any articles in any review articles in CASTA or ANA. So this is the only study which was discussing about long-term results of internal bracing in ACL repair and reconstruction. So this again included 10 biomechanical studies and 13 clinical studies. Of the clinical studies, there are only four were speaking about ACL reconstruction and internal bracing. So these were the biomechanical studies, most of which are published in ANA or JBJS. And with that, they concluded that there is definitely lower graft elongation and a higher ultimate failure rate for the graft plus brace construct. And there is no stress shielding on the bone. So if you look at the clinical studies, as you can see, there are only 5 studies comparing with respect to reconstruction internal bracing. Again, one of the studies comparing ACL repair internal bracing against reconstruction. So in essence, there are only 4 studies we have about ACL reconstruction and internal bracing. Again, if you look at the follow-up period in these studies, the maximum data we have is only up to 2 years follow-up. So just quickly look into the individual studies. The first study is an Indian study published in the International Journal of Orthopedic Sciences. So again, from KGMU Lucknow, it's not an index journal, and again, very minimal follow-up after only 6 months. I couldn't find any further follow-ups with this study. And another study is by Bodan for includes 60 patients with 30 patients with suture augmented ACLR against standard ACLR. Again, a 2-year retrospective follow-up study. They concluded the suture augmentation definitely improved the arm and had less pain and higher return to sports and similar failure rates. One study by et al. Published in again in ANA Again, a retrospective study with comparing 36 patients with ACL interbracing against 70 with standard ACLs. Again, follow-ups only 2 years. And there are no signal. The results are in favor of ACLR and internal bracing. However, a point to note is the authors of this study are affiliated to Arthrex, and they are proponents of the use of Arthrex internal bracing system. And last study is again a case series. It's non-comparative with 37 patients. Again, follow-up only 12 months, showing good results. So to conclude, internal bracing definitely reduces graft elongation, and there's no reported severe adverse effects with the use of internal bracing in terms of any immunoinflammatory reactions. And definite biomechanical studies convincingly show that it helps in early post-op protection of the grafts and aids in healing. So can be, as put forward in more studies, can be considered in patients with small grafts or in possible uncomplained patients like an athletes or in obese patients. So take home, so the data we have regarding ACL and internal bracing, either with regards to repair or reconstruction, is very scarce. The maximum data we have is only up to 5 years, and so long-term results are awaited. The biomechanical studies definitely support the use of internal bracing, again, depending on the depending on patient selection. So long-term results of ACL repair are still not convincingly known, and if considered, maybe ACL reconstructing internal bracing can be considered type 1 and type 2 proximal ACL tests in adults, since there are very high failure rates in children. And ACL reconstruction and internal bracing may be considered if additional cost is not an issue in patients with small grafts or with patients with suspected non-complaints like very highly active or obese patients. Thank you, sir.
Thanks, Praveen. Well done. And I just want to do this so that, because a lot of patients in the OP are asking for it. How many cases have they done in Lucknow?
Very minimal, sir. 25, I think. Yeah, 25 against 25, sir.
Okay, thanks. Thank you.
Yes, sir. Thank you, sir.
One doubt to clear. Ravi, now this graft elongation was tested for hamstrings, you know?
Yes, sir. That's
Anything
more of biomechanical study, sir.
Anything comparing PTB?
No, sir. I didn't come across anything. All for just hamstrings, sir.
Okay. Thank you.
Yes, sir.
Sir, shall we end the session, sir?
Yeah, please.
Thank you all.
Good night, Gopal. Good night.
Good night. Good night.